So there will be 8 talks, and each has a time of 7 minutes. So the first one is by Dr. Pooja Mehta, Pediatric Retinal Disorders, Interesting Cases.
So good afternoon to this post-lunch session. I'll be sharing some interesting cases, and because it's the pearls in pediatrics, I thought that I'm going to share some pearls that I gathered along my pediatric retina journey. So I've divided into few sections and what I have learned from these cases. So let's start with the first case of a preterm child with gestational age of 32 weeks and birth weight of 1860. And when we saw the child was can you dim these lights? So the child was 34 weeks at that time.
You
Oh,
can't
okay.
put off this light.
So don't they know the session
Okay,
is
that's
going
all.
on? Because they can't see, na, with just so much of light. No, those
No, we can see here.
see it. These people can't see.
Okay, I think let us
Okay,
move
we'll
on.
continue.
If
So
it is not going
I'll
to
just
change.
describe the findings. So both I had severe retinal ischemia with sclerosed vessel and total shallow exudative RD. And what we did it was injected ranibizumab. Now, question is this ROP? So yes, this is ROP, and we were not the first people to see it. It has been seen earlier by the LBP group and reported this kind of a severe exudative ROP. But it was first described by the Shankar Netralaya group, where they actually told the mechanism to be because of fibrinogen leakage into the retina that causes an inflammatory response, and that causes leukocyte infiltration and subsequent exudative retinal detachment. So 1 week later, after the intravitreal, the exudative RD improved, and at the last follow-up, both eyes were vascularized up to the zone 2 anterior. So this is the second case of an 11-year-old female child who came basically with squint and was sent for fundus evaluation. The left eye showed a retinochoroidal coloboma. Now the right eye, right, sorry, there's a mistake in my presentation. Sorry for that. The right eye had optic disc pit, exudation with telangiectatic vessels temporally and in the ITQ, and there was a vasoproliferative tumor-like lesion, and also the child had retinochoroidal coloboma. So the diagnosis was Coats disease with secondary vasoproliferative tumor with optic disc pit and RC coloboma, and for that we did green laser. So we do find many pathologies at once. So the first pearl was be prepared for the atypical, because pediatric retina is full of surprises. Coming to the section 2, so this was a child who was a baby, 5-month-old with squint and referred for prominent eyeball to rule out congenital glaucoma. Now, when we looked into the details of it, not just there was tessellated fundus, but periphery had thinned out areas, and there was opalescent vitreous strands. The other eye, if you look at it, it just looked like there was tortuosity of vessels, but if you look closely, there was a shallow retinal detachment. So we did rule out congenital glaucoma and went ahead with a belt buckling surgery. And post-operatively, once the retina attached, we did a 360-degree barrage laser. Now, interestingly, this child also had peripheral avascular retina, which was revealed on RETCAM fundus fluorescent angiogram. And because of these atypical features, we did a genetic testing. We suggested clinical exome sequencing, and we found a mutation in the COL18A1 gene, which was a pathogenic variant suggestive of no-block syndrome. And the same mutation was found in carrier state in both the parents. So what is no-block syndrome? It's a triad of high myopia, vitreoretinal degeneration with occipital defects. Now, what I learned from this case is pediatric RDs can be extremely shallow and subtle. Underlying syndromic associations must be suspected when the RD presents at a very young age. Genetic testing holds the key in diagnosis of symptoms and must be considered when the family is extremely inclined towards knowing a definitive diagnosis. So this is another case which is actually referred for ROP screening, and the referral letter mentions sclerosed vessels. What we actually saw was lipemia retinalis, and I advised the lipid profile. The triglycerides came out to be 1898, very high, and we started the child on formula feeds, and after that the lipemia sort of improved. This is another child, again came for ROP screening. and had a syndromic facies, and also was a known case of corpus callosum agenesis. So right eye had tessellated background with hypoplastic disc, and there was some fibrosis in the periphery and peripheral avascular retina, which was well seen on the fundus angiogram. Left eye had a folded retina over the disc, and there was no significant family history. So coming to corpus callosum agenesis, it is actually the most frequent brain anomaly in children. It can have a non-syndromic and a syndromic variant. The non-syndromic one is associated with poor vision, refractive error, and squint, but the syndromic one is associated with a lot of fundus features, which Aicardi syndrome is something we all know, but it's also associated with Walker-Warburg syndrome, which is probably the most diagnosis in our case, and even FEVR has been described with corpus callosum agenesis. So fundus evaluation is a must for syndromic patients. So pearl number 2 is look beyond the eye for syndromic and systemic associations. Okay, section 3, this is a case of stage 4B retinal detachment. We had a tractional and an exudative component with peripheral fibrosis with vascularly active component. So this case was managed by lensectomy and vitrectomy. And after 1 week, there was some, the fluid had settled to some extent, and after 3 months, we had a good anatomical outcome. So why I showed the first case is in perspective of the second case, in which we saw tractional schisis at the macula with a peripheral fibrosis. And in this case, we did not do vitrectomy. We only did a belt buckle and external approach along with laser. And at 2 weeks, we had a resolution of the schisis, and at 2 months, we had flattening of the posterior pole. Okay. In opposition to this, we had another stage 4B detachment, again tractional and exudative component with peripheral fibrosis and vascularly active component. Now this child had multiple systemic issues, and we were waiting very long for the general anesthesia fitness. In the meantime, we injected intravitreal anti-VEGF, and this is how the child was pre anti-VEGF, and this is how it was post anti-VEGF. We had a good settling of the macula, although there was some peripheral residual traction, but because of the systemic nature of the child, we decided to observe this child. So third pearl is less is more, and perfect is the enemy of good, whether when it comes to pediatric retinal surgery. So these are my pearls, and I have to thank my mentors from whom I have gathered these pearls in my experience. Thank you so much.
Yeah, it's very informative to. Very often we come across such cases which give us surprises when there is squinting, especially. We look at the retina and we find something interesting, and then we send directly to retina department, and they find a lot of other things also. So I think. Whenever we can afford, or it's possible, it is good to have a genetic analysis in these children, which with the other associations also. Thank you, Dr.
And the pediatric retina practice is incomplete without the pediatric opthal, because ultimately it's the rehabilitation which really makes the outcome a bad outcome or a good outcome. So thanks to all of you here.
Thank you.
Yeah, we can have some comments from Dr. Diksha. She does a lot of ROP. Any suggestions, opinion? Mike.
And they are not even associated in literature, so we just thought that okay, this child was extremely unlucky to have so many things at once. Thank you.
Dr. Divya, your comments, please. We would like to have your comments as well.
So I guess it's because when we inject, we need to look at heavier babies developing crunch. So the thing is, this child was around 38 to 40 weeks. We were prepared to go in and do the surgery, but just to buy time, we gave the anti-VEGF, and luckily, this child did not have a worsening. So yes, when we inject in heavier babies, we have to be prepared that we need to go in. It's just like tractional diabetic detachments where anti-VEGF can actually accelerate the detachment. Yeah, thanks for bringing out that very important point.
Next. Next. Next.
Next is traumatic pediatric cataract by Dr. Tanmay Biswas.
Good afternoon to the audience. I'll be presenting on traumatic pediatric cataract.
One second. We cannot see it on the screen here. Yeah, it's only there. It's not here. Okay. Yeah, I think you can start. It will come after 30 seconds. Doesn't matter. Yeah.
So I would like to declare no financial interest. So coming to the introduction, so the trauma can be mainly, as we all know, can be divided into a closed globe or the open globe. The blunt trauma cataracts, that is the closed globe cataracts, are usually stellate or rosette shaped, and the penetrating trauma cataract are usually progressive cortical opacification, the speed of which can depend upon whether the lens is capsule is intact or it is ruptured. So, what is important in assessing pediatric traumatic cataract is history taking. Although children are poor history givers, but still, if you want to know what they have got the trauma and how long was the trauma, whether the trauma is a trivial trauma or a significant trauma, because sometimes the children will present with a history of very trivial trauma, which is unlikely to cause a cataract. Maybe the cataract was present long before, and just because of the trivial trauma, they have come up for the examination. So in these cases, you have to really take into mind there might be a dense amblyopia behind. So you have to counsel that beforehand. Coming to the examination, before dilatation, you have to check the BCVA, fixation preference, pupillary reflex, IOP, and iris for any defect. Small metallic foreign bodies sometimes produce an iris defect, and through the zonules can lodge into the retina. So you have to be very careful for that. So sometimes that is more so because most of us receive the patients after the optometrist has seen and dilated, and we receive the patients dilated. So you have to tell the optometrist that before dilatation, just let us see before dilatation, so that these fine points should not be missed. And after dilatation, lens examination and zonules, posterior segment examination, and biometry if you planning surgery, and anterior segment OCT, and if the child is cooperative enough, for ultrasound biomicroscopy. So what are the challenges? So the pediatric eye itself is a big challenge. We know that a pediatric eye is not a miniature adult eye. So we have to take that into account, and the progress should be accordingly. So as I was saying, mode of trauma. So how much is the trauma amount of trauma matching with the amount of cataract? Now sometimes you'll give a history that the sibling has put in scratched with the nail or something like that, and you see a total cataract. Well, a scratch with the nail will probably not produce a total cataract. So maybe the cataract was less initially, maybe it has progressed to such levels. So expect a dense amblyopia. Pre-op assessment. So not only the ocular but systemic pre-op assessments are also very important, because you are anticipating the surgery under general anesthesia. Surgical challenges, sometimes not everything can be assessed pre-op, so you have to keep in mind that you may face hurdles during the surgery. So be prepared, and sometimes maybe even keep the retinal surgeon in hand in case you need him or her. So the general principles are, usually the anesthesia is almost always general anesthesia unless the child is an adolescent and can cooperate. So the incisions are usually clear corneal. Well, when we are implanting acrylic foldable IOL, sometimes economic constraints can lead us with the PMMA IOL, so can opt for scleral incisions in those. So anterior capsule is a manual capsular access. If the anterior capsule is compromised, you can go for vitrector access. And hydrodissection, if you see a total cataract or if you don't know the status of the posterior capsule, it's better to avoid hydrodissection. Posterior capsule management, if you feel that the child will not cooperate within a year or two's time, when the child will develop a posterior capsule opacity, you have to do a posterior capsulotomy, provided there is enough capsule, and you have to assess that. And the IOL ideally should be in the bag or a 3-piece IOL in sulcus, preferably with an optic capture, and also expect a higher inflammation. So I'll be discussing one single case due to time constraints. So this is a 4-year-old child who had injury with a stone 9 months prior. Primary corneal wound repair was done elsewhere, presented to us with a corneal scar and a total cataract. So this is the examination. The right eye was the eye. So it was PL plus, PR accurate, central linear scar, anterior segment quiet, posterior synechiae was present, total cataract, IOP in Goldman was 14, the fundus had no view, other eye was normal, so the right eye USG showed normal, so we went ahead and planned the cataract surgery. So here we are making a small incision with the MVR blade. And then we are putting some dilute epinephrine. So, but there is very poor dilatation due to the posterior synechiae. You can see the central linear corneal scar. Even after visco, the pupil doesn't dilate much. So we went ahead and did some synechiolisis, and there is a little bit of bleeding, but still there is not adequate pupillary dilatation. So we went ahead and put some iris hooks, and here you can see that the anterior capsule and the posterior capsule are adhered. They are very thick. Even the vitrector was not able to cut it very efficiently. So we had to make small snips with the micro scissors, and then the vitrector could cut it easily. So here we are putting the 3-piece acrylic IOL, and at last was the nose. Anterior vitrectomy was limited. Anterior vitrectomy was done, and suturing of the ports done, and last the visco wash. So checking all the ports, they are not leaking at all. So the summary is every traumatic eye is different. You have to assess proper pre-op assessment and still expect surprises on the way. So each eye requires a tailor-made approach, means involved other subspecialty. A trauma may have caused an orbital floor fracture, so a plastic intervention might be needed. A foreign body might be lodged in the retina, so a retinal colleague, you might need to call them, and also needs innovative steps to avert difficulties. Thank you.
Thank you for that crisp presentation. You mentioned so many investigations in your first slide, UBM, ASOCT, and all these things. What is the use of all these things when the pupil doesn't dilate?
Yes, sir. Most of the time, all the investigations we will not be able to do because the child doesn't cooperate well. So these ideal scenarios, if all of these can be done, is okay. But then
I think ultrasound is what you would require mainly because the posterior segment, and that can tell you whether the posterior capsule is ruptured or not.
Yes.
So with one investigation, you would know both these things. Other anesthesia investigations, okay, I mean, you're having a lot of machine works, but it's just your clinical skills what matter there, and what best you can do without subjecting the patient. Because if the patient has a globe injury, okay, then obviously the repair is first, and the timing of the cataract extraction is very important. So whether you would do it as a primary procedure or you would wait for the eye to quieten.
If the anterior capsule is ruptured, what I usually do is when the lens matter is coming out, so I wash up all the lens matter that is coming out, and then can keep a phakic, and later when the eye quietens down, you can do a biometry and put a IOL and that secondary IOL.
Yeah, biometry is again an issue because you have corneal scarring in a penetrating eye injury, and obviously it might not give a good result even if you do a secondary IOL. But yes, the indication for removal is if you have lens matter in your anterior chamber, that is you have to remove. Otherwise, I think probably a secondary procedure would be much better. And these eyes are much prone to a lot of inflammation.
Yes, sir.
So if we can avoid that sulcus area, probably that would be better wherever avoidable. But as you showed, I mean, it's such a fibrotic capsule presented after 9 months. Probably there is no other way, I mean, you could do it.
Thank you, sir.
So any other comments? Any questions? Yeah.
Yeah, that is yeah.
Mike.
Yeah.
It's very important. Sometimes the main suture removal will take time, isn't it? So even then, you can still give glasses, whatever is possible, and don't wait for all the sutures to be removed to give glasses, because that will take a long time, isn't it?
What I give 10-0 vicryl sutures for the side port and main port, so removal is not.
Corneal tear.
Oh yeah, that is.
That big suture.
Yeah. So actually, this patient presented when they presented the corneal sutures were already removed, so only the scar was present. Okay, so thank you. Next, Doctor. So I would like to call Doctor.
Difficult situation to see your child struggling with vision because most of the time they are not aware themselves, and it's very, very important to address these problems early so that we can prevent a lot of other problems which are vision dependent in future. So each child has specific visual milestones, and it's very important for us to know these so that we can pick up these problems early on and treat them early. So pupillary light reaction can be seen at 30 weeks. They generally give eye contact by 2 months of age. Contrast sensitivity develops by 7 months, and child can have 6/6 vision on Snellens by 5 years of age. So vision impairment in children could range from no vision to low vision, and we'll divide it into visual impairment in infants and older children. So when do we say that vision is not normal? When we are seeing wandering eye movements or visual inattention, lack of response to familiar faces and objects, there's no eye contact, if the child is staring at bright light or eye poking, or there's nystagmus, involuntary eye movements, and if the vision is not 6/6 over 6 years of age. So it requires a thorough workup, and history is very important here. So need to know the onset, severity, and progression of vision symptoms. Look for antenatal history, where you need to rule out if there is maternal infection, any trauma, diabetes. Postnatal history of prematurity, low birth weight, seizures, any neurological issues, any medical anomalies. Family history is very important. Rule out any history of consanguinity. Prior use of spectacles, LVA, difficulty with near task and mobility, and also ask for any difficulty the child has in day-to-day activities and what impact it has on the child's well-being and the psychosocial functioning. In infants, look for lack of eye contact with the family members, photophobia, eye poking, and squinting. And in older children, you may see that child may be holding the reading material very close to their face, rubbing their eyes, or adapting abnormal head posture or intermittently closing one eye. They may also have history of night blindness, squinting, and some children might be very clumsy. They may knock over things and trip often. Coming to the ocular examination, look for fixation and falling of light on objects, response to the visual stimuli like face and toys. Quantify the vision according to the age appropriate chart, and also taking into considerations the child's cognitive function. Pupillary examination must rule out any RAPD. Look for nystagmus and oculomotility disorders like Duane syndrome or congenital oculomotor apraxia. Very important to look for color vision, because many a times when the color vision is absent, child may have difficulty with recognition of objects. So we can utilize Lia puzzles or colored matching balls or Nishihara's test. Similarly, contrast sensitivity is very important, because sometimes the child may have normal vision, but because of poor contrast, they may have difficulty. So Hiding-Heidi test or Pelly-Robson's test can be used. Dynamic retinoscopy is very important to look for any accommodation lag. Visual fields in children can be assessed with Lia wand or smiley faces, and in older children we can also do confrontation or Humphrey's visual fields. A detailed dilated slit lamp examination is very important to look for any anterior segment pathology. Again, coming to retina and optic nerve, rule out any optic nerve pathology, foveal hypoplasia, or retinal pigmentary changes. Cycloplegic refraction is a must because many a times refractive errors are missed out. And wherever necessary, one may have to do a post-Mydriatic test. So when you're looking at a examination in infant, if the examination abnormal, if the external examination is abnormal, you are either looking at microphthalmos, aneuridia, albinism, cataract, or glaucoma. And if the external examination is normal with or without nystagmus, and if the fundus is normal, you can utilize ERG. If the ERG is normal, you are either looking at a congenital infantile nystagmus or congenital oculomotor apraxia, delayed visual maturation of cerebral visual impairment. If it is abnormal, you know that you might be probably looking at LCA cone dysfunction or retinal dystrophies. When there's an obvious abnormal fundus, you need to look for any pathology in the vitreous, retina, and optic disc. So let's look at this chart. If you're looking at an apparently blind infant who has infantile nystagmus, look for any anterior visual pathway disease like bilateral optic disc abnormalities. If it is there, you need to rule out any supracellular tumors, hydrocephalus, or any disc anomalies which could be coexisting with CNS abnormalities. If that is absent, then look for photophobia, high myopia, paradoxical pupil or ocular digital signs, which could be suggestive of a congenital retinal dystrophy. Here the ERG could help. However, if the ERG is negative, you're looking at an infantile idiopathic nystagmus or a neurological nystagmus. When the infantile nystagmus is absent, one should look for saccadic eye movements, and this can be elicited with vestibular ocular reflex. Now, if that is normal, you should also look at history of prematurity, perinatal hypoxia or abnormal neuroimaging, and seizures. And all this, if it is positive, could also be erring towards cerebral visual impairment. When all this is absent, you're probably looking at a child with a delayed visual maturation. When the vestibular ocular reflex is absent, we are looking at a congenital oculomotor apraxia. So this is a video of a child where you can see that the child is having difficulty in eliciting saccades, and child is using a head thrust to look into the lateral gazes. Often these children could have a delay in motor and speech. So when you're looking at poor vision, no nystagmus, normal eyes, there are two things which we need to keep in mind. First is delayed visual maturation, because the neurological status is normal here. The ERG will be normal, flash and pattern VEP will be normal, MRI scans are normal. So visual outcome is generally good, and it improves over 3 to 5 months of age, and this is generally a retrospective diagnosis. Other entity that one should keep in mind is cerebral visual impairment. This is a spectrum of in this spectrum, the child could have limitation ranging from low to high functioning. In low functioning, the vision is generally poor. They can have a stormy perinatal period, and HI is the commonest cause. And abnormal neurological status like global developmental delay, seizures, and cerebral palsy, etc., is seen. MRI scans are abnormal, like hypoxic ischemic encephalopathy changes or periventricular leukomalacia can be seen in these children. So when you're looking at an older child, if the external examination is normal, so either you're looking at a functional cause, refractive errors, or something like a retinal dystrophy. Also, cerebral causes should be ruled out, and look for optic nerve issues. When the external examination is abnormal, rule out any anterior segment pathology in the cornea, lens, and also look at glaucoma changes. Wherein in the posterior segment, you need to look at obvious changes in the retina, vitreous, and the optic nerve. Other investigations like ERG and VEP could help. It is important to have consultation with pediatric neurologists based upon the causes. Neuroimaging studies may help for CNS and optic nerve lesions. So it's not just what the child is seeing, but it affects a lot of other aspects of the child's development, like communication, playing and socializing, talking, telling the difference between day and night, sitting, crawling, walking, learning to read and write, playing. So what is the best thing that we can do for this child? Early intervention. So correcting easily treatable causes like refractive errors, cataract surgery, providing them vision therapies, educating the parents and the child, and also additional supports would help. So helping parents learn how to bond with the child and interact with them in a way that supports their development. And also it requires a multidisciplinary approach. Thank you.
Thank you, doctor, for taking us through the various developmental this thing. But what we have to remember is not to tell the parent, even when you obviously see some this thing, that don't abruptly say that child cannot see or something like that, as far as CVI is concerned, because there are other multiple pathways which can help the child see. And whenever you have some this thing, when you ask for a MRI or something like that, they would have done at 1 month of age or something like that, immediate. So in that case, it won't show any abnormalities, it will be normal. So you may have to repeat the imaging sometimes to pick out this thing. And the other thing is hypoglycemia.
Yeah,
That
hypoglycemia.
history also is very important, that also
Yes.
can lead on to
Yes, yes.
this thing.
Yeah, I mean, your delayed visual maturation is a very important thing.
Yes.
You have a lot of children coming who are not, maybe who are a little beyond their milestones. I mean, so they get your VEP done, there's abnormal, and you suddenly start, it's like an alarm reaction. I mean, what's happening? Why is the VEP? So these have to be tackled very carefully. I mean, repeat VEP is very important in these cases. Many a times when you have these developmental delays, a repeat VEP would be normal.
And I
So
think close follow-ups would also help.
yeah, I
so
mean,
that
so
we know that
the
we
child
are-
would start developing. I mean, it's a delayed
Yes.
milestone. He would start developing
Yes.
a little later. So the visual maturation would also be a little delayed. So all these things. I mean, it's the counseling when the parents are very bothered about my child is not seeing clearly. So the
Yes.
counseling is very important, and getting the having a right approach and follow-ups. Probably one-stop diagnosis is not the right thing in these patients. I mean, you need to have these children under follow-up to exactly know what's happening before you come to a conclusion.
Yeah, absolutely. Thank you.
Please remember, they're going to become myopic, and you have to give them glasses because they are a high risk of amblyopia as compared to a normal child who you might not give myopic refraction in the when he's an infant. So in these preterm babies, you need to get in early and start the treatment to prevent amblyopia.
Yes. Thank you.
Okay,
Thank you,
next
thank
we
you.
have a little reshuffle. Next, Dr. Soumya is going to present Don't Cross Your Eyes to Diagnose Crossed Eyes in Children.
Good afternoon, everybody, and thank you for the opportunity. So I would be discussing on Don't Cross Your Eyes to Diagnose Crossed Eyes in Children. This is going to be a comprehensive topic covering all the things about esotropia. So most of the times when we see a squint, apart from the squint specialist, all of us start having a dizziness, especially in the general ophthalmic clinic. I would be covering this topic in the following headlines, looking at diagnostic caveats of importance, what are the surgical caveats that we look at, a couple of cases to understand them, and summing up and a take home. The most important things what we'll cover up with the cases would be diagnostic caveats. You should always use fixation targets when we are measuring or when we're evaluating a squint in a child. Apparent limitation of abduction is something that always has to be kept in mind in any case of esotropia. The high AC by A ratio, the importance of cycloplegic refraction, the distance near disparity and the gaze angle disparity, the palpebral fissure changes and signs of co-contraction, and the fundus examination. So these are specific points with respect to esotropia apart from the regular points that we look in a squint evaluation. So first and foremost, confirm the esotropia. However, the younger the child, always perform the alternate prism cover test. You can use any of the fixation targets you use. This child is apparently referred for the squint and the child does not have any squint. Besides, this child needs a little time to play with the child before you actually elicit the esotropia. Don't use occluders, don't use your entire hand, use a thumb according to the size of the face. So you see that the child starts, you see that ET coming in. So first confirm the esotropia before you proceed on. The next important thing would be to use fixation targets. So this child again come with esotropia. The moment you ask the child to start reading is when the esotropia comes in. So always use fixation target before you jump in and or use your torchlight. So again, use both for distance and near the fixation targets, which are normally used for vision charts, which are kept in the clinic. So that could be used for confirming it. So the first and foremost important, use vision targets. Second important caveat, in any case of esotropia, the most important point, apart from doing an alternate prism cover test, knowing what is the amount of distance and near deviation. Like in this child, it's a 3-year-old child with 35 prism diopters of ET for distance, 45 for near. Most important thing, that information that you would need is a cycloplegic refraction. You can use atropine in less than 5 years of age or a cyclopentylate however you're comfortable with, and look at the cycloplegic refraction, and that gives you a diagnosis as refractive accommodative esotropia. So that becomes the second caveat. Similarly, even in an older child, like this child who is a little older child, coming with a similar complaints, ocular movements being completely normal, look at the cycloplegic refraction before you conclude the case. So cycloplegic refraction must in any case of esotropia. The third important thing is apparent limitation of abduction. So if you have had ET for a very long time and you check the version movements, you are going to find that the abduction is limited or the levoversion and dextroversion is limited. Like in this child, though the video is taken post dilation, you see there is an apparent limitation of both dextroversion and levoversion. The easiest thing to do is to cover one of the eye, check for the adduction movements, confirm that it's an apparent limitation of abduction, not a true limitation of abduction. That helps in your diagnosis again, that it's not something dealing with a six-nerve palsy or a DRS that you're dealing with, and helps you to come to a conclusion. The next important thing would be high AC by A ratio. This child, look at the child seeing through the distant glasses and near target, there's obviously an esotropia, which is around 20-25% diopter. Bifocal glasses corrects it. So looking for distance correction when you're given a hyperopic correction, look for the near deviation again. Check with +3 lenses if there is any difference which is made in the angle. So distance near disparity, again, think of two important things. One, if there is normal ocular movements, it's usually a high AC by ratio. If it is an abnormal ocular movements, then you obviously know the cause. The next important thing would be when there is an abduction limitation. Like in this child presenting with esotropia, has a definite limitation of abduction in the left eye and a gross esotropia, versus this child which has a abduction limitation of either of the eyes. The most important feature would be here a palpebral fissure changes, which is apparently seen in the second case vis-a-vis the first case. So that brings us to the most important thing. Whenever there's a limitation movement, a limitation of abduction, always look for if the primary gaze deviation is in par with the limitation of movement. If it is in par, then you're dealing with six-nerve palsy, not a DRS. If the movement limitation is same along or there is a difference. If you look at the first case, the movement limitation is almost the same in up gaze and in the down gaze. Vis-a-vis this child, if the down gaze movement, abduction movement is much better than the up gaze movement. So that again helps us understand that it's a DRS case versus a six-nerve palsy. And look for signs of co-contraction, which is palpebral fissure changes. If you are lucky enough in an ET, you will always have a upshoot and a downshoot, which again goes in favor of a DRS. Again, look for distance near disparity, which is very, very obvious in a six-nerve palsy, not in a case of DRS. The next important caveat would be to look at the old photographs. Like this child came with the movement limitation, which has been there from a very long time. You ask him the history, the child, this is at the first birthday, this is third birthday, fifth, seventh, always had this. So it's a case of congenital six-nerve palsy, though it is rare. So old photographs or photographs looking at is very, very important. Again, this is another child who the mother says the child has been squinting. When I look at it at the clinic, he's apparently completely okay. The old photographs, couple of them, absolutely strained. Call him on another day, the child has a ET. So this is a case of a cyclic esotropia. So you have days with esotropia, days without it. So always look for old photographs before you conclude that the child does not have a esotropia and send him off. Now, when we have diagnosed that this is probably one of the causes, or what the diagnostic clues that you have to pick up in a case of esotropia, let's look at some of the surgical caveats. Timing of surgery, again of importance, especially in a case of infantile esotropia. The limbus insertion distance, again in esotropia, and handling paralytic and restrictive etiology. A few cases before I conclude. So this is an 8-year-old child presents with squinting from the age of 1 year. The child has good vision because of cross fixation. So obviously you would chosen to do a 3 muscle surgery and correct him. So in any case of infantile ET, even when you're operating later in a later age, always look at limbus insertion distance. Like in this child, it was only 4.5 mm, not 5 mm. So your surgical calculation would differ based on it. In the second case again, 8-year-old child presenting with diplopia. The child was apparently normal, cycloplegic refraction almost okay. So this is how the child was a year back also before she came to us. So got a neuroimaging done, ocular movements normal. The esotropia is comitant. It's around 50 to 55, gaze, the distance near disparity none, gaze angle disparity none. So this is a case of acute acquired comitant esotropia. Again requires surgery after 6 months, no change, underwent surgery. This is a gentleman with esotropia, apparent abduction limitation, small amount of upshoot. Case of DRS, you would choose between SRT or a bimedial recession. Last case, what we were looking at in the congenital sixth nerve palsy. So you have options in terms of full tendon, partial tendon, or a modified Nishida. Modified Nishida proves effective in this particular scenario. Again, don't forget to measure axil length in certain cases of extreme ET. Like in this gentleman had around 30 millimeter in the right eye, left eye has 29 millimeter. The most puzzling part of his eye was the right eye was left aphakic. So the refraction was only +1. So unless you did the axil length, you would never come to a conclusion. Again, this requires a loop myopexy. And so in summary, always use the appropriate diagnostic tools to sum it up, and then come to a diagnosis based on what jigsaw puzzles that you are able to finish, and then choose the procedure accordingly. So esotropia needs a methodical approach like any other squint evaluation, vision evaluation, detailed evaluation of squint, arrive at a diagnosis, and then conclude. So this is a list of committed and incommitted esotropias that you would normally look at. So any squint, there's no magic in the magic per se. It's always in the details. Thank you very much.
Thank you, Dr. Somya, for that excellent presentations. I mean, a lot of things going on. You're doing surgeries as well for simple cases, and the complex cases, of course, it's you have to decide case to case, because obviously the risk involved in those cases, and probably you might not be able to give the result which is desired by the patient. So counseling is very important in those cases. And sometimes in these younger patients who are like you have a small angle esotropias, probably the parents are quite bothered. So in those cases, probably what do you consider? Do you ever feel the need to give botulinum toxin in these patients?
Yes, you could. Again, it largely depends on the case. If you're talking, especially in terms of acute committed esotropia with a small angle, yes, Botox can be one of the option. But I have a limited experience with Botox.
Thank you.
We have given in acute onset ET, like this COVID times, we have given Neelam. I think you are presenting in your presentation. I think so. We already presented also, and it is with free paper we presented. Okay. If it is done early, it gives very good results.
Very good results.
MRI being normal, and then you give the Botox, it works well. We saw this in this recent COVID times when we had all acute ETs and myopes and all that. In acute ETs, it works. But if it crosses that 6 months, then it doesn't really help so much. So
congenital sixth nerve palsy is also quite rare. So do you do neuroimaging in these patients? I mean, congenital sixth nerve is quite a rare thing to have. Yes. So when do you do neuroimaging in these patients?
This child presented to me only at 8 years of age. Okay. So I still got a neuroimaging done because the diagnosis were very obvious from the photographs.
So we had a slow growing tumor in one of our sixth nerve child who was gradually on the diplopia was worsening. Okay. So obviously, I mean, that's why in these cases imaging should be done in these sixth nerve.
Yeah. I had one interesting case. A child with progressive myopia actually come with a small angle esotropia. Very recently, one of my colleagues' relative brought in with a small angle esotropia, had a very early onset sixth nerve paresis. Imaged her, she had a neuro tumor which came up. So that was not picked up, thinking it is an esophoria with myopia. So.
Thank you.
Sure. Thank you.
So next would be the ROP management in day-to-day practice.
Good afternoon all, and thank you for the opportunity. I'll be just discussing ROP management in day-to-day practice. Just to give you a background, that we know that our country has the highest number of global preterm births, around 3.5 million per year, and we contribute around 10% of the estimated global visual impairment due to ROP in 2010. There has been estimates that around 2 lakh neonates require screening for ROP every year, and about 20,000 of infants in our country require treatment. So that's a huge number, and we need more ophthalmologists to do ROP screening. ROP management actually involves three facets. First of all is the early detection of sight-threatening ROP. For that, we should know who are the at-risk babies, when to screen, and how to follow up. And then important aspect is treatment, which is when offered timely has the best success rate. So we should know whom to refer or treat, how to treat, and how to follow up. And then a very, very important aspect is the post-treatment follow-up. And so we should be aware of what are the ROP sequelae, and a major component would be management of the refractive errors. So, who are the at-risk babies? We know that in 2017, the RBSK guidelines increased the screening criteria to include all infants up to 2 kgs and gestational age less than 34 weeks. But if the child has had a stormy neonatal course, even heavier babies needed to be screened. In the recent most, the National Neonatology Forum in 2020 has still adopted the same, and we now we screen all infants who are less than 2 kgs if the gestational age is not known, or less than 34 weeks. More importantly, that even heavier babies need to be screened if there is any history of oxygen exposure more than 6 hours, any history of sepsis, episodes of apnea, need for blood transfusion, exchange transfusion. In the absence of reliable records, any history of NICU or SNCU admission also becomes one of the criteria to include the child for screening. When to screen, we know that we have to do the first screening within day 30 of life. For neonates who are less than 28 weeks of gestational age or birth weight less than 1200 grams, if the gestational age is not confirmed, they should be examined earlier by 2 to 3 weeks. And at least we should try to do one screening for all infants before discharge from the SNCU or NICU. How to screen? We need to dilate with half the strength that we use for adults. So it should have 2.5% of phenylephrine. Earlier we used to make them. Now a commercial available preparation is available, so it has become easier. So 1 drop instilled 2 and maximum 3 times with punctal occlusion, and wiping off the excess from the cheeks has to be given. Standard of care still remains indirect ophthalmoscopy, though the use of wide field cameras, including the indigenous ones, including the smartphones, has increased objectivity to screening. However, there have been often questions raised whether that by ophthalmologists that if you don't have a camera, is our screening still valid? Well, yes, it is valid if you have documented clearly, made a proper diagram, and made a correct and a proper diagnosis using standard terms. So the standard terms that we have to follow is the recent classification, which is the ICROP3 classification, and we should use the terms that are used in the classification. For example, we know that it is stages. Sometimes we get referral using terms such as grade ROP. There is no such term as grade 1 or grade 2. It is a stage ROP. So the staging 1 to 5, we all know it starts from a flat demarcation line, then acquires volume to become a ridge. The ridge then has extraretinal proliferation, then it is called as stage 3. When it becomes a tractional retinal detachment, it not involving the fovea, it is 4A. When it involves the fovea, it is 4B. In the recent classification, it has been accepted that the detachments in ROP can be both tractional or exudative, as was in the case highlighted before. And the stage 5 bedside classification has been incorporated to include 5A. When clinical examination, you can see the optic disc. 5B when the optic disc is not visible, and 5C when you have 5B along with anterior segment abnormalities such as posterior synechiae, shallowing of the anterior chamber, cataract, or a corneal opacity. Aggressive posterior ROP is now to be termed as aggressive ROP because it is recognized that it may be the features can be in zone 2 also. So the posterior word is dropped. The features that you more likely see the tempo of the disease, which is a prominence of the vascular features rather than the ridge, and a rapid progression to retinal detachment, a prominence of plus disease, flat neovascularization. That is when you classify aggressive ROP. Apart from the traditional 3 zones, we now have a posterior zone 2, which is an area of 2 disc diameters that is surrounding the border of zone 1, which is included in the recent classification. In our country, because of the atypical forms and heavier birth weights getting forms of ROP, we also often use the terms such as a zone half or a posterior zone 1, which is within the zone 1, wherein even the fovea is not vascularized. So you may come across these terms also. These are not standard terms, but they are often used. Then this is the term which has been described by Professor Dogra is the hybrid ROP, where you have features of a mixture of both a staged and an aggressive ROP. You may have a semblance of a ridge, but prominence of the vascular features. That is called as a hybrid ROP. Plus and pre-plus, we know that plus for us becomes an indication for treatment. In the recent classification, to identify plus, you have to look at the vasculature within the entire zone 1, not just the small area around the optic disc. So we've let go of the terms quadrants, but we look at what are the features in the entire zone 1, and we know that it includes arteriolar tortuosity, vascular dilatation, poor pupillary dilatation, tunica vasculosa lentis. When to treat? The ETROP guidelines are still followed, and these are the indications of treatment. In addition, all aggressive ROP has to be treated. The management of ROP, we started from cryopexy, but laser photocoagulation still remains the standard of care. We now have an addition in the form of anti-VEGF therapy, and bevacizumab, ranibizumab, aflibercept all have been used. Surgery is the most recent new innovation in the form of MIVS, so lens sparing vitrectomy and scleral buckles. But an important aspect is the post-ROP sequelae and the whole list that we need to keep in mind when we are following up these children. For laser, we need to treat as early as possible within the first 48 to 72 hours in a near confluent pattern to the entire avascular retina. And in very posterior disease, we need to delineate the zone 1 first. So these are just examples showing laser treatment. The outcome is good, and in most cases, more than 80% success rate with laser alone. Anti-VEGF is used in selected cases of very posterior disease, zone 1 or zone half, poor pupillary dilatation, severe TVL because of one, the rapid resolution of the acute phase, and the opportunity to allow retinal vascularization to progress. However, we have to remember about reactivations and the need for long-term follow-up, which we need to be careful for with anti-VEGF therapy. So these are just examples of pre and post anti-VEGF. I'm not sure if they are visible, but and one example of a persistent avascular retina, which we need to keep in mind and which needs a subsequent treatment. So these terms have been also included in the recent classification, the reactivation and the regression. And surgical approaches for 4A, 4B, and 5 are there, and we have had good success in terms of surgery for ROP. These are few cases which have done very well after surgery. So, and then for as sequelae, the most important sequelae that we need to keep in mind is myopia. And those of you who are interested can go through this paper where we have shown that the ROP myopia is more often than not is non-axial. It's not an axial myopia. It's more lenticular or anterior segment changes. That has to be kept in mind. So to conclude, timely screening and treatment can result in favorable outcomes in a majority of cases, but all children of ROP require long-term follow-up for the sequelae. Thank you.
Thank you, Dr. Diksha, for that wonderful illustration of cases and summarized in a short time. What is the you can say, which stage of ROP do you commonly see in the clinic in this tertiary care hospital?
So actually, if we look at our own center, if we have two sets of children who are coming. One are the inborns that which are born in our own center, and those that are referred. So in the inborns, we most commonly see the staged ROP, and most of that ROP is the one that regresses also on its own. So we do very few treatments among our inborns, but the outborns that are referred, a majority of them are aggressive ROP, and so they are the ones that mostly need treatment.
So the ones coming which are referred are they there's a delay in presentation, yes, or why do you find that
no, not always are they delayed presentation, though we have people even in 2023 we have people or infants who have come who have never been screened and have presented with stage 5, but because they come from a lot of other level 1 level 2 NICUs where the neonatal care is not standardized across the country, so there are a number of factors. So the neonatal care does have a bearing on the type of ROP, and especially the zone half, posterior zone 1, probably these are the ones who are directly related to the care that is given, because we don't see that among our inborns.
And do you give anti-VEGF for all these aggressive ROPs?
No, as I just mentioned, our indications would be severe cases of zone half or posterior zone 1 and selected cases of zone 1 anterior. We don't give for, I personally don't give for zone 2 disease.
APROP or aggressive
Aggressive
ROP?
ROP if in posterior zone 1 and anterior zone 1, not in posterior zone 2. No, do laser for those.
For aggressive ROPs, you give anti-VEGF in the first go?
Yes, for those, like I was just mentioning, those which are posterior zone 1 or zone 1 anterior or severe TVL, we will give anti-VEGF as the first go and then wait and see the response to treatment. And then generally we treat only when there is a reactivation.
Okay,
Only if the, yes.
My question is, how often would you see these patients after injection?
Yeah.
And how long would you do? And when would you decide to go for laser?
Yeah. So again, we give injections in both the eyes on the same day. So we treat as like two separate patients and take all care. Then we see the child within the next 24 to 48 hours, see the response. Most first response would be dilatation of the pupil and reduction of the pus. If that has happened, then we see the child in first week and then every 2 weeks. Now every 2 weeks, if it is going fine, we keep the child under follow-up and we treat only at if there is a reactivation of the disease. Only if parents do not understand the need for regular follow-ups or are failing to comply with that or cannot come from very far, then we somehow take a decision around 50 weeks if there is still persistent avascular retina significant more than 2 disc areas. Even if there is no reactivation, we then take a treatment decision to do laser, but otherwise we generally treat at the time of reactivation.
Investigation or do you do clinically?
First is clinical. So if you have made clinical photographs, you have imaging, very good. If you don't have imaging, then your clinical photographs and your records have to be re-evaluated. Return of vascular tortuosity, dilatation, and appearance of a faint resemblance of the ridge that was not there before at the vascular avascular junction is the sign of reactivation. So that time, if that is clinical, we do have the angiogram which we do in and confirm. But if it is not there, then clinical, these are the signs of reactivation.
Shall we go on to the next?
Okay, the next topic is the rise of myopia. It's very
No. That speaker is not there. Simple to complex strabismus.
So simple to complex strabismus.
I will be talking on simple to complex strabismus. So my job is done easy by Dr. Soumya. She has already covered most of the point. So simple strabismus is not so simple. One has to do a comprehensive ocular examination, including the all 9 cardinal gaze measurement, and patching and amblyopia therapy is must before doing surgery, and this has to be continued even after doing surgery. In cases of IXT, the world is still updating it to what are the protocols to be followed for the whether to do early surgery or to wait. So it is better to do surgery in cases of IXT after 4 to 5 years of age to get better sensory motor result. Very minimal amount of esotropia, there is no need to correct it. And phonics incision have definitely advantages over limbal incision, and it is surgeon and case to case based preference whether you want to do adjustable or non adjustable, and avoid very large recession and resections in a single eye because it limits not only the field of action but also causes significant palpable fissure changes. So now coming to deviations from horizontal, whenever you are tackling inferior oblique, always do it symmetrically in both eyes. And in cases of A pattern exotropia or esotropia, avoid bilateral PTSO if there is high stereopsis, because patient can complain diplopia in down gaze if you are doing bilateral PTSO in bifoveal fixator patients. In cases of Helveston syndrome, which is a triad of A pattern XT with superior oblique overaction and DVD, usually surgery involving all the 4 oblique gives us good result. And in management of complex strabismus, beside all this investigation, the other investigations like orbital CT scan, MRI brain, thyroid function test, and tensilon test are required. And it needs extra time for surgery, and one has to think that nomogram do not help in each and every case. Each and every case is different. So in cases of Duane's retraction syndrome, we for all these special syndrome, we use the term congenital cranial disinnervation syndrome, and DRS is one of that. In ortho DRS, just correct the upshoot, and same time you have to maintain the orthotropia in primary position. In cases of exoduaris, one can do a single eye splitting with LR recession, and depending upon angle, asymmetric or symmetric LR recession is done. So this case of right eye exoduaris with a large left face turn was corrected with 9 mm of lateral rectus recession with Y split with good post-op correction and with no face turn. This was case of left esodr's with left head turn corrected with MR recession and lateral rectus Y split without any recession. So in cases of DRS, SRT is advocated to improve the abduction, ocular alignment, and to correct the abnormal head posture, mainly in esotropic DRS. And in this case of left eye DRS, MR recession was done along with Brooks modification of superior rectus transposition to the lateral rectus to improve the abduction and to improve the face turn. Now, Brown syndrome is one of the most complicated case because whether to treat or not to treat, and surgery is indicated only if there is large hypotropia and anomalous head turn, and usually silicone expander or chicken suture gives somehow better results. Now coming to paralytic strabismus, in cases of third nerve palsy, you have to look for involvement of superior oblique, whether there is any aberrant regeneration, how is the lateral rectus, and whether pupillary involvement is there or not. In cases of sixth nerve palsy and third nerve, you have to see whether globe is crossing the midline, whether palsy is partial or complete, and how are the saccades. And transposition surgeries are advocated whenever there is no resolution and no improvement after 6 months of the paralysis. So in cases of sixth nerve palsy, the commonly done surgery is Hammersheim Jensen procedure. Hammersheim can be augmented by single augmentation by resection or with double augmentation by intermuscular augmentation. SRT with medial rectus recession also gives good result, and Nishida procedure is also no split, no tenotomy, and it is done whenever there is risk of anterior segment ischemia. So most of the studies shows that whatever augmentation you are doing, it is always helpful in not only improving the angle of deviation but also in improving the binocular field and abduction. So this is a short video on the journey of Botox to the double augmentation. In initial stages, you can give the Botox, and later you have to rely on this transposition surgery. So in this case, the superior rectus was isolated and it is split into two halves up to 10 millimeter from the insertion, and then 6 cervical suture is passed, and this half is disinserted and attached near the lateral rectus, superior border of lateral rectus. Similarly, inferior rectus is also isolated and it is attached near the lower border of lateral rectus. In cases of augmented Hammersheim, after isolating the superior rectus and inferior rectus, we pass suture at around 4 millimeter from the insertion, and then this superior lateral half is then transposed to the lateral rectus, and the resection can be done prior to it or after attaching the half to the lateral rectus. Similarly, inferior rectus is also isolated. Inferior rectus is also isolated and it is attached. Resection can be done and it is attached at the lower border of the lateral rectus. So in this particular case, bilateral augmented Hammersheim along with MR recession was done to treat the traumatic large angle sixth nerve palsy. In cases of third nerve palsy, periosteal fixation of lateral rectus is done whenever there is large exotropia. And a new modality of treatment which is very useful is medial transposition of split lateral rectus, which is given by Gogitz. The only problem is that it can cause choroidal effusion, so one has to be careful. One has need not to pull both the ends very tight. So this video is of split lateral rectus. The lateral rectus is split into two halves, and then superior rectus is isolated. Superior oblique is isolated, and then posterior tenectomy of the superior oblique is done, and the superior half of the lateral rectus is then passed below the superior rectus, and then it is transposed near the medial rectus. Similarly, the other half of the inferior half of the lateral rectus is also taken and passed below the inferior rectus and it is placed near the medial rectus. So this, in this case of traumatic third nerve palsy, NTS SLR was done with good result. In cases of bilateral superior oblique palsy, one has to see whether there is any reversal of R by L or L by R, and one has to look for arrowhead pattern. So in this case, bilateral IO recession along with 9 mm LR recession gave us a good cosmetic result. In cases of large angle exotropia, modified Nishida can be done because whenever you are involving multiple muscle, it prevents the anterior segment ischemia. In case of MED, which is a restrictive cause, double augmentation and NAPS procedure is usually helpful whenever FGT is negative and inferior rectus is not tight. And in cases of lost inferior rectus muscle or partial avulsion, one has to look for the careful sections of CT scan to look whether the inferior rectus is attached or it is lost. And this case presented to us after 2 years of trauma, and we did inverse snap procedure to correct the hypertropia. This is one rare case in which the hypoplasia of inferior rectus was seen, and in MRI, the cross-sectional area was very less for inferior rectus, and it was treated with inferior oblique anterior transposition to correct the hypertropia of 30 prism L by R. In cases of high myopia, Yokohama procedure is usually done in which superior rectus and lateral rectus myopexy is done. While in cases of exotropia, hypotropia complex in high myopia, nasal loop myopexy of superior rectus and medial rectus can be done at 8 mm away from the insertion to prevent the sagging of the eye and to improve the limitation of abduction. Now, coming to last slide, these cases are very complexes, and the table itself shows that to remember that which type of CFEM we are dealing with. Sometimes it is difficult to diagnose, and whatever surgery we do, we are always ended up with dissatisfaction and undercorrection. So these are very difficult to treat, and one has to approach very meticulously. So thus, a meticulous planning and planning in each and every case can give patient a cosmetic correction, can improve the quality of life, and patient can have a diplopia free field. Yeah. Thank you for this.
Thank you for dealing with so many complex cases. It's always a difficult job when these present to you, because obviously you cannot give them the free movements that they want, and the main aim is just to get them into orthotropia and counsel them obviously what is going to happen, like maybe in Hamel-Schemes or anything. You might uh, give them a little bit of abduction in those cases with 6 nerve palsies, but yes, the full range is quite difficult, and then probably augmenting it with the Botox, as you rightly said, I mean, some of these cases. So I mean, it no doubt, I mean, we don't have so many cases, but yes, when they present to us, one really has to gauge what is going on, like a periosteal fixation, what you're saying in third nerve versus a lateral rectus transposition. So that again is not an easy procedure to do.
Yeah,
so again, in those cases also, the patient is not going to have any movements except maybe a straight eye.
Yeah, it
So
takes time also, and we are also afraid whether we are not going to give any new tropias to the patient and some new thing to.
yes, I mean, they're usually large angles when they present with third nerve palsy, so probably a neutropia would be you can less of a chance as rather than giving them what they want. I mean, they'll be much happy with the surgery what you've done. But yes, the lateral rectus should not be tight in these cases, and even you could do a superior and inferior oblique tenotomies and just go around and augment these sutures depending upon the deviations. What I think has been described by Rohit Saxena as well, because we had failures in our series when we did a lateral rectus transposition for 90 prism diopters. We had to do a medial rectus plication, even though it was a palsied muscle because of third nerve palsy, but then just a tightening procedure to get the child into ortho. So I mean, from case to case basis, you have to do all these procedures, and it's a nice illustration. Thank you.
Thank you very much.
Any questions? Any comments before we? I don't think we have any other speaker.
Is Dr. Yogesh Shukla here? No. So he had 2 talks. So
I think.
So any questions regarding any of the sessions, anyone? So we have a little bit of time in hand.
Yeah, if we had known, we could have had a more discussion.
Okay, then we can wrap up this session. So I would like to call all the speakers and the panelists to have a photo.